Like first of all, start off. We're going to present our project and the importance of research and innovation and just a relationship that we had with NB-IRDT and the Department of Health. Like these initiatives are so important to allowing new concepts and innovation to take place. And although we're going to present you a research study, but some of our learnings are actually being implemented in our clinical services. So there's not just the residual of what we learned from the research, there's actually a direct application to our clinical services that we're delivering in mental health or occupational medicine or sleep services and so it's very beneficial and that the support that we receive like this from the province and working with NB-IRDT has been exceptional. It was very encouraging to work with them and they were just great on collaborating and being very reasonable and really clearly articulating what we needed to do and that. So it was we want to thank them and recognize the Department of Health for that. But also what I need to do before I start that, I need to recognize our team, like our team at Canadian Health Solutions. You're going to see we have a bunch of pictures at the bottom of we're very fortunate that we have some very strong representation, starting with Dr. Aaron Metcalf, who's the head of our research, and he gives us the structure and guidance and helps us. He facilitates so many things and coordinates and has that research expertise that allows us to have the framework to move this forward. And I want to thank Sarah Wiseman, who was directly involved in research nurse, but also a background in psychiatric nurses services and their sort of skill sets. Those two are the only two on the call here, I believe. So what I'll do is we have a whole team behind that that went into this. So I'd like to acknowledge them, but I won't name them off individually. We'll go to the next slide because I think the background is to understand that Canadian Health Solutions, we deliver health management solutions. We focus predominantly on occupational health, mental health, and disability management with the goal of using developing evidence-based solutions that will have an impact on healthcare. We feel that our healthcare system we're so fortunate to have the healthcare system that we have, but in order for it to stay current and to compete and continue to provide our services, it needs two fundamental things, and that is good people working in it and innovation. And that's where support of innovation through these research, which eventually leads to implementation of these research, leads to innovation solutions. And so what our hypothesis was that if we looked at our current delivery system of healthcare, could we develop a project that would allow when we look at primary care as being the main gateway for the majority of people to access healthcare in our province or actually in Canada, we said, and with recognizing that depending on the jurisdiction, anywhere from as low as 15% up to 25% of people are having difficulty accessing primary care, we said, is there an opportunity to develop a solution that could be both technology-based, would have structure, could be geographically distributed, we could use resources that are in the community, and that would allow people to deal with managing modifiable risk factors, which is their wellness, which actually, if you manage these when you're managing actual medical conditions, that these are the adjuncts that we use to also help manage medical conditions also. So our project was to say, can we develop a platform that could actually be used to facilitate access to the principles that are used in primary care and management of medical conditions? So that, next slide, please. So the hypothesis that we're going to present to you and how we tried to study it was to again, could we access geographically distributed preventable healthcare using communities? We partnered with local communities and an app-based platform with the goal of improving modifiable risk factors within the specific population to in turn help avoid morbidity and mortality within this population. Next slide, please.
Okay. Thank you, Dr. Lies. It's a really great introduction to the plan, I guess. And my part is to talk a little bit about the design of that program and what the implementation looked like. So from this graphic here, you can kind of see that there were 5 main points that we focused on when it came to the design of the Wellness 55 project. The first being assessments of modifiable wellness factors. So this was done using an app platform and standardized test, including fitness tracking using a smartwatch, and then identifying risk profiles. So people who met certain score points would be encouraged to take a look at those areas of their lives or their well-being and potentially focus on them as goals for modifiable risk. The second part was knowledge transfer and learning modules. So we developed a number of learning modules to help with participants working on their own with our support to learn more about a lot of the modifiable risk factors that they would have identified in the first part. This also included group learning sessions and assistance with navigation to resources when needed. And we'll talk a bit more about that in a second. The next step was goal setting and self-awareness. So for participants, having those standardized tests and the information presented to them about where they sat on all of those different metrics was in itself a big step towards improving their self-awareness, their well-being, because it a lot of times tended to be things they hadn't even necessarily thought about, and sort of opened their eyes a little bit into what areas they might want to work on. It gave them the opportunity to take that personal ownership over the goals that they set. We did use SMART goals for this, so specific, measurable, attainable, relevant, and timely. And used the data of retesting for things throughout the program to see how they were doing. So that included in the next section, accountability and assistance, so virtual goal check-ins and access to goal coaches. So we had those small team, we were mighty. And there were a few of us that worked together with the clients to be available if they had questions or needed help or just needed direction. And a lot of times those were very simply just conversations about how to reach the goals that they wanted. And it was really a great opportunity and an honor, I would say, for us to help with that. And then finally, of course, reassessment and progress tracking. So monitoring their progress with their goals, monitoring the changes that would have happened with any of the testing that we did, and ensuring accountability and modification of lifestyle. To get a bit more specific about our design and intervention, you can see on the side here, we've got a list of all of the community partners that we had with the program. So this was operating in the Greater St. John area, which included St. John itself, the town of Rothesay, the town of Quispamsis, Hampton, and also Grand Bay Westfield. So very, if you know St. John area, southern New Brunswick area, that's a pretty broad area that we worked in. And all of those communities were very involved and eager to engage in a program like this. The program itself was 6 months, and we focused on 9 core assessments that included function, wellness, and self-efficacy. All participants were given a smartwatch to help with achievement tracking. There were a total of 21 self-directed learning modules, which varied on topic from, you know, physical movement, sleep, nutrition, to managing emotions and stress, and some financial type things, grief, very broad topics that could be relevant to a lot of different people. As I mentioned, we had 5 community hubs, and we also had one-on-one coaching appointments with clients where they would come to those hubs to meet with a coach when they wanted to review what was going on. So this slide, I just wanted to give a brief look at sort of what the app looked like. So imagine these on a phone screen, and it's 4 different screenshots. So the first one kind of shows what participants saw when they looked at the wearable data that was taken from their smartwatches and how it was presented to them. So you can see in this example, it's the number of steps taken across October 2023 for this person. The next one shows the sort of home page that they saw with the app, which helped to guide them through the program. And we made sure that it was very clean and simple and easy to use, just so that we wouldn't have too many people struggling with the technology aspects of things. The next one shows the tasks. So these, for example, this person has their goal setting to do today, and also the extra surveys at the top are actually learning modules that they can do. And then setting goals, where we have this is sort of the general overview of what the learning modules look like. It was very simple, very easy to maneuver, and sort of provided tidbits of information going through instead of just like one long page of information. So with that, we started to look at, for our analysis, the total group improvement on those 9 core measures that we used. And we actually did a focus on clinically at-risk subgroups. So looking at, you know, people who were already scoring in the well sections of a lot of these metrics, you know, great. And we wanted to see how they did too, of course. But we did focus in and kind of zoom in a little bit on people who were in those higher risk categories for those measures. We also used a composite score frailty index to link the improvements to literature and what was expected in the health outcomes. The smartwatch data that we collected, unfortunately, was affected by wear time. So we were able to look at frequency of use for the smartwatch, and we will have a bit more on that later as well. The data related to goals, including selected focus goals and SMART goal tracking, is still being analyzed. So not all of that's going to be included today, but we do have a little bit on that as well. And we also had focus groups a couple of times throughout the 6 months to look at qualitative input from participants, and we'll touch base on that as well. The first data, though, that we can present is our demographic information. So our goal was to have 200 participants. We had 254 that enrolled and a total of 199 that completed the program. If only we could have got one more, we would have hit that 200, but here we are. We thought that was pretty good. And because of the continuous enrollment of the program, so because participants would enroll and start their 6 months immediately, but obviously we would be continuing to enroll people until we hit the target. There were participants who were able to continue the program beyond the 6 months as planned, just because the program was still running for other people. And we had 70% that actually wanted to stay in the program beyond the 6 months. And we did note that attrition did not change demographics for the sample. Though the numbers are for the 199 that completed, the numbers for the 254 that enrolled were almost exactly the same for demographics. So as expected with our community hub distribution, St. John had the biggest population of participants, which makes sense. It's the biggest area, biggest population of people. Then it was Grand Bay, Westfield, and then a fairly even split between the smaller communities outside of St. John. We separated our age distribution by young seniors, older seniors, and pre-seniors. So we actually started, as the name implies, Wellness 55. Our participants at 55 years of age, and then went from there. So young seniors were the majority of our participants between 65 and 74. Pre-seniors, so under the age of 64, sorry, were 32%, and older seniors 23%. And I think, if I recall correctly, we obviously ranged from age 55 was the youngest, and I think our oldest was, I want to say 87. So we had a pretty good distribution across that age bracket. And then gender distribution, about 3/4 female, quarter male. And I would say that overall, we were not overly surprised about that finding. It's not unusual in health research for us to have more females than males. Interestingly, I think a lot of the males we did have, there was sort of a bit of a split. There were men who came along with their wives. And then we also had a few men who had perhaps recently lost their wives or something like that, and were really looking for a community program to engage in. And so it was great to see that, and to have people engaged that maybe wouldn't normally do something like this. One thing that we did look at for the goal selection, so participants had the opportunity to select 3 goals, just so that they weren't working on too many things at once and getting overwhelmed. Based on the literature, we opted for 3. So what we saw is that the main goal that most participants selected was physical activity. Then next was nutrition, and then next was sleep. So we ended up sort of referring to those in our learning modules as the big 3, the 3 that everyone sort of wanted to focus on. And then from there, you can see, stress, leisure time, thinking, self-care, friendship, and various other things that they could choose to work on. But again, I think not surprisingly, the big ones were the ones that a lot of people struggle with: the physical activity, the nutrition, the sleep. And we did a lot of work with participants on how those things impact all of the other aspects of your life as well. So even though they might have focused on physical activity, they still got information on how that impacts, their thinking and their life outside of those aspects. And that is my bit.
Great, thanks, Sarah. So now we're going to move on to more of the statistical analysis comparing the pre and post tests. So there's a few different ways that we chose to look at this. So one was just at the individual tests and if they changed. And then we had the Frailty Index, which we'll get into, which was a composite, a way to look at multiple ones all at once. And shuffle them together so that we could get kind of an overview. And then finally, we'll look at some of the changes that happen in categorical risk stage for people that were at higher risk. So when we first look at just the overall central tendency, was there some changes? We found that for the overall group, there was some maybe smaller magnitude to moderate magnitude changes for mainly the things like digital health literacy, total wellness, which was an interesting one. So that was a rather large measure that looked at multiple components of wellness, such as things such as exercise, spirituality, social health, kind of a holistic perspective of health. We had some marginal changes in the WHO disability assessment, the WHO-DAS. So that one looked at how any disability you're experiencing affects your function. And then we had no significant changes at the whole group level for sleep inventory or health engagement. But we did find some changes in self-efficacy, as well as in healthcare self-efficacy. So at the group level, we found those were the largest changes were associated with those kind of educational components of health. So that was quite interesting to us. If you want to go to the next slide. So in the Frailty Index, we used a model based on Ken Rockwood's Frailty Index. It's one of the 2 more popular models of looking at frailty, and it's a continuous quantitative model. So what it does is it takes somewhere around 30 individual indicators that we've collected, and it puts them into a composite index where they're all scored on a ratio and then added together. So you can go from 0 to 1, 1 being the most frail, 0 being the least frail. So frail and most frail are associated with the highest likelihood for transfer to long-term care. And that's why we're most interested in it when we're looking at a way to sum up the positive effects that our study had when we can, get into the tie into the literature on frailty and the changes that we were able to get and what that might extrapolate to at a population level when we look at how it might affect things like morbidity, transfer to long-term care, and hospital stays, for instance. So we found on a continuous look at it, there were significant improvements in the frailty index from pre to post that were highly significant and of a small to moderate size. But then if you look over to the graph on the right, we have the frailty levels at baseline in 6 months, and we have them categorized into non-frail, pre-frail, frail, and most frail based on literature review. So what we find here is the most frail, these are the individuals that are most likely to have relatively rapid onset of higher morbidity or mortality, as well as long-term hospital stays. We found that, in fact, 3 individuals left that category overall. And we found also some shifts from frail to pre-frail, and you'll see post that both the pre-frail and non-frail categories grew. So this seemed like some good news. So if we go to the next slide. This is where we broke it down in more detail. So this is really interesting to us because if you think about frailty and age, the relationship is thought to be a correlation, right? And so the more you age, the more frail you get, and that doesn't generally get reversed. So what this graph shows is it shows the numbers at baseline, and then it shows individuals that stayed the same or converted when you get to post. So you'd expect to see a lot more red lines converting to a worse frailty index category than you would improvements. And what we found, in fact, is that wasn't the case. So although we saw some some relatively minor shifts when we looked at it up above, we actually saw a number of individuals that were converting to more frail, as you'd expect, but even larger amounts at each category that were converting from a more frail state to a less frail state. And that included 10 individuals that went from pre-frail reversed to non-frail, and 2 individuals, in fact, that were already categorized as frail went all the way up to non-frail at post. So some fairly enticing and interesting and exciting results when we think about what this program could actually do in terms of transformation, even in a relatively small period of 6 months. Yeah, and that includes 11 individuals that, in fact, left the most frail, counterweighted, of course, against 8 that went into the most frail categories. But also, this highlights some individuals that we can look at to see what helped them convert, and maybe bolster program development for future versions where we can see why it worked so well for them. Because pretty dramatic results when you see 5% change from that frail to most frail to a lesser frail category. Next slide. So this is the whole group results at pre and post categorized by risk. So of course, you can look at a lot of these factors in terms of continuous variables, but you can also, most of them have cut points for risk. So they're usually developed as screeners that are used to look at individuals that are less at risk or more at risk. And so they come with both hazard ratings or cautions, and with absolute cutoffs for you're at most at risk. And so low risk is blue, moderate risk is yellow here, and high risk is red. And what you'll see if you look over here, in almost every case except for the DHLS, the Digital Health Literacy Scale, I'll talk about in a second, but we see at least some reduction, if not more dramatic reduction in some of these, such as ability to navigate the healthcare system. The MOHC had quite a significant reduction of people that were at risk back to a normal baseline. Another interesting one was the HUDAS, which saw quite a large proportion of people that moved from at risk to not at risk. And so these are some interesting ones because it looks at how disability affects your cognition, how disability is affecting their ability to do everyday tasks like shopping, a whole host of things that are very predictive of ability to age in place and maintain a more robust, less frail physique and composition. So I guess we can move to the next slide on that one. So when we look at specifically those individuals that were highest risk across all of these factors, there were clinically significant improvements for those risk factors from 20 to 45%, depending on the one that you look at, with, again, some of the highest one being on the HUDAS, when that change happened for a very large proportion of the population. And I guess I can just mention the DHLS from the previous slide. There was actually some negative improvement, or people got worse. And we think that what happened with this in terms of digital health literacy, this was the ability to like use things like apps or use things like remote portals to discuss your health. We actually believe what happened is we made individuals more cognizant of their shortcomings. So we actually saw that as a good thing, because they were actually realizing what they had to improve and changing their estimation of their own abilities. But other than that, all improvements across the board. Next slide, please. So this is an exciting new piece of data we haven't been able to present before. So this is the first time that we're presenting this one, and we're preparing for peer review next. And so this is the exit interview. So we were able to canvass, in most cases, about 185, I think, of the 199 responded for these questions. And it asked, how has your overall experience with the program been? How has your overall experience with the platform been? How has being a part of your Wellness 55 program improved your overall health and well-being? How likely would you be to continue in a program like Wellness 55? And how likely would it be for you to recommend it? So in all cases, they were well above 50% endorsing pretty high numbers here. So the average for many of them were near 7, above 7 and above. And if we move to the next slide, we have a density gradient on this, actually. And what it shows is not only was the central tendency quite high, but in many cases, we actually had the preponderance of participants endorsing a 10. So they thought it was the best. Which, was really a huge result for us, because, David mentioned, Dr. Elias mentioned at the beginning, we had growing pains. This was a pilot project. We were trying to test a number of concepts, and we were really working with everybody to bring it together. And it was, I don't want to say surprising, but it was very validating to see that the experience was so positive here. So even with something that, was in an early development stage, when we took it live, we really found that the concepts here with the goal setting and the SMART goals really had a very large impact, and people really felt it. Yep. Next slide. So this relates to smartwatch use, and I think Dr. Elias also wanted to make a little bit of a comment from the clinical side on this slide. But basically what this shows, in the literature, there's a 10-hour a day kind of thought that in order to get good smartwatch data to look at program improvement, you need about 10 hours a day. And what happened was what we found was utilization went down quite a bit over time. So valid days went down over time. But nevertheless, people were still using it. So they weren't using it for 10 hours a day. They weren't making it a constant part of their life activities, but people were reporting they were using it to monitor their sleep specifically for a goal, or they were using it to monitor their exercise progress specifically for a goal. So although it wasn't the best for the program evaluation, it was a very highly utilized tool. Just for many, they used it only at certain times. I
think why I was interested in this element, because we feel that we had some real learnings in this area regarding the use of smartwatches, and the biometrics that we get from them were so significant and so objective and so beneficial that as a both as a diagnostic health tool, it can be used for what we can spot as trends in heart rate variability that could be predictive of disease. What we see is we get to see people's sleep architecture, and people underestimate the benefit of the sleep and how we can advise on them. So our learnings regarding the use of smart watches from when we started to the end was, one, a significant understanding that these tools have a real strong opportunity to contribute to both population health and to managing medical conditions. Two is that technically we'd understand which watches to use and why we would use them, such that they have the longer health life, how to connect better, and that. So we had some real strong learnings that we could share with other people who want to use smartwatches, and that within their either research or clinical programs, and that. As I say, we recognize we did have some failures, and that we had, we see compliance of using it kind of go down, but we do think that with some changes to our programs and with additional, we kind of found this out probably a little later. We would probably structure some things to get higher compliance, because the benefit of the data. And this is what our research studies, but we continue to use these in mental health, and we're getting higher and higher compliance in that population. So we have some learnings that we've learned from this program, and that we continue to improve compared to this data. So
yeah, so great. So I think lastly, I would just say there was a bullet 2 slides back I didn't point out. In addition, 92% of participants in that exit interview felt that Wellness 55 program had been beneficial to their health and wellness. So that was 92% overall. So yeah, there it is. So that was, I think, worth going back and pointing out. Thanks, Sarah. Yeah, so we can go ahead now. I think that concludes most of the stats section.
Yeah. Thank you. So just a brief touch on the focus group findings, some qualitative data that we had. The 3 biggest themes that we were finding in focus group were the interest in community engagement, the overall improvement of health awareness, and sustainable behavioral changes. So we selected some quotes just to highlight those. So the first being, a participant said, the ability to come here to be able to chat and discuss, knowing that there's somebody you can go to, but also the groups, being with other people, talking, feeling that you're out, not feeling that you're out there all by yourself. So that engagement and social connection was really big for a lot of participants. Second, without this study, my wife and I would have never started looking into our health and being more mindful about our everyday eating habits. So again, that idea that even sort of having awareness of what was going on and being more reflective of their own health and well-being was making a big change for people. And then finally, any changes are better. Any positive change, albeit small, is an improvement over before. And I think I've made quite a few changes from there. And my husband has also, so that we might not have made those changes had we not joined. So again, people learning that even small changes can make a big difference over time, and really leaning into those modifiable factors in their lives that they have control over. Related to, I think, a lot of what we were just talking about, we have some challenges, limitations, and lessons learned. So specifically, there were a lot of coaching sessions in demand for technology use. We did do some learning sessions on that, but likely more would have been useful for a lot of people. That seemed to be their biggest struggle. Even so, we did our best and were as available as we could be. We're also working on a French language version of the program right now. This one was exclusively in English. The smartwatch use, as we've discussed, obviously we had some difficulties with that. And I think that harkens back to the first point here, of course, which is that some more training and coaching surrounding that would be useful. The specific SMART goal feedback initially was limited based on what we could do with the app that we had, but we did find a workaround about halfway through our program. So we do see a lot of sort of general improvements as opposed to more goal specific. But that would be something to look at in the future as well. Again, we did see that there was some shift for certain people from lower risk to higher risk, or vice versa. And Dr. Metcalf mentioned sort of that additional analysis to see what was different about those participants and the engagement metrics, so that we can sort of target exactly those aspects and improve them. And then finally, focus groups data suggested participants wanted to learn more they just wanted to keep learning and learning and learning. So we want to make that possible and expand on, beyond the 21 learning modules we had and get other topics available. Back to you, Dr. Metcalf.
All right, thank you. So we've already covered some of this, but we found that wellness and self-efficacy did improve at the whole level. So when we're looking at change that affected everybody, it seemed like a lot of it was educational and just changing their perspectives, which was quite interesting. The composite frailty index score improvements suggest that long-term impacts and lowered risk of multi-comorbidities transferred to long-term care and mortality. So this gets back to people coming out of higher frailty groups down into lower frailty groups and an extrapolation based on population research. About a third to a half of high-risk participants at baseline were able to improve their risk profile on most of the 9 core measures. So again, we found that we were really having the most effect on individuals that were at highest risk. So not only did they have the most room to improve, but of course it's the most important to improve them. So that was a very good finding. Program screening also identified, so this is another part of this. So the geographically distributed model, we're encountering people that don't necessarily have a primary care physician, that maybe haven't been as attentive to their health as they need to be. And we identified 12 participants through our screening model that needed healthcare intervention for serious undiagnosed both psychological and physiological conditions. So a small number when you're looking at the absolute number, but when you take that 200 and looked at it from a population perspective, just the simple act of screening could have a huge impact on population health here. And about 50% of participants did use our coaching services, some of them many times. So they would come back monthly or even bi-weekly in some cases, and just to have short discussions either in person or remotely about their SMART goal and about how they were achieving it. And I know a popular one was sleep, another one was exercise. And so it did have a big impact having some touch points there. It was highly utilized. About 12% of the individuals used community navigation. So we didn't talk about it at length here, but we've also developed a navigation library. So that's matching people with a need to a community service. So that we thought that was an important part of the program, and it was in fact used quite frequently. And then participants also reported an enhanced sense of community and accountability, which we thought was also a very important impact.
So I guess to kind of wrap things up, I think if we go back to the original hypothesis and we look at our results, we do feel that we did have some learnings, and also that we do feel that we were able to validate some components of our original hypothesis. The first one would be, we recognize that all across Canada, primary healthcare is our access points, and that right now there's a lot of Canadians who do not have access don't feel that they have access to primary healthcare. So not that this can replace it, but could it serve as some sort of support for that system? And we do feel that, one, we show that we tried to develop a low touch digital service that even seniors could use, and that we could use community-based assets that are already existing there, municipalities, to help deliver this. So checkmark, they were very willing, and that these community hubs served as show that we don't need to have additional investment in this infrastructure. The second thing was, were we able to can we have an impact on population health? And I think that's important in changing and having an impact in a positive way on population health that could potentially move people within the frailty indices or other healthcare indices to suggest that it could prevent future burden or reduce their morbidity and even mortality into the future. And so I think that we've been able to show that, yes, you can have an impact on that. And then the third element was, is our population willing to actually interact with it, what we'll call predominantly a system to support and maybe get a lot of their wellness or some sort of healthcare knowledge transfer from. And the answer would suggest that overall the experience is positive, and people, they are looking for access to healthcare metrics, structure, and feedback that doesn't always need to be delivered directly by a healthcare professional, and that's or directly by primary care. And what we're seeing here is that it was predominantly a digitally based program. We had support. You need to have that personal support and communication to facilitate that. But what it suggests to us that it is scalable. If you start to get into a scalable factor, that it should be able to apply to scalability. And we go to we had some significant learnings, and we could improve upon our technology and our platform and that. But I do think that the majority of New Brunswickers would be willing and are looking, when they do not have access to primary health care, that a lot of people want to manage their own health care and their own wellness, but they want to be empowered with something that's structured, that holds accountability, gives them measurement, and gives them feedback, and potentially can screen and identify a medical condition if it's more significant. And that's, so I think that that's what we've been able to do with the program. Aaron, you want to speak to the Frailty Index and what your the third
Sure, yeah.
bullet,
So
yeah.
Yeah, so this is based on some extrapolation to population, based on expectations from public health literature on what being frail or most frail translates to in terms of near horizon conversions and healthcare problems. So if you just take our numbers and extrapolate them up to, say, a population of 200,000, which is a bit above the senior population in New Brunswick, but also a bit below the population if you include people 55 to 64. So that would be the three people that converted. That would be 3,000 most frail individuals in that larger population might avoid a year of long-term care. So you're at higher risk to come into long-term care if you're in that most frail category in the next 2 years. So that could translate to $120 million of healthcare savings for more healthcare, and not to mention the change in life that has to aging in place, right? Not going into long-term care. Similarly,
I think, I think another factor too, that's a direct quantifiable regarding long-term healthcare, but you're going to see that the basic elements of what we provided within the program was modifiable health risk factors. Okay, so these modifiable health risk factors are the same health risk factors that you would dealing with chronic diseases. So the majority of our chronic diseases, these same modifiable health risk factors are the ones that you're trying to manage in diabetes, cardiovascular disease, metabolic syndromes, mental health conditions. So there's an overlap that we see that, the core, we talked about it being under the issue of wellness. But if you manage these modifiable health risk factors and you improve outcomes and people's standing in those areas, it correspondingly will have a benefit in managing those chronic diseases and actually increasing their resiliency, and maybe prevent them from actually moving into developing some of these conditions also.